in adolescence and young adulthood. So just some opening reminders here. If you are listening as a group, please go to the chat window and type in the name of the person registered, as well as the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final count. Some general reminders here. All attendees are in listen-only mode, but we do want to hear your questions. To ask a question during the session, use the chat tool that appears on the bottom right side of your control panel. We'd like to hold all answers to questions till the end of the presentation. You may type that at any point. If you have a technical issue, please go ahead and type that and I'll address it right away. But in terms of giving them to presenters, we'll hold off to the very end. Attendees will receive an evaluation survey after the webinar. Please let us know how we are doing and any new topics you would like us to cover. We do archive all of our webinars. To access previous webinars, simply go to sdhforall.org/webinars, and this webinar will be recorded today. The objectives today include describing the Bright Futures Initiative and related resources, identifying practical Bright Futures and quality improvement strategies to enhance the quality of preventative healthcare services, and utilizing Bright Futures tools and resources for application to the school-based healthcare setting. We have two presenters on the call, as well as a panelist. Our first presenter is Dr. Barbara Frankowski, as well as Dr. Marion Errol. Dr. Barbara Frankowski is a professor of pediatrics at the University of Vermont College of Medicine. She has been a practicing pediatrician in Burlington, Vermont for almost 30 years, has provided health and sexuality education in local schools, and started several small school-based health centers in the area. Dr. Frankowski served for many years on the American Academy of Pediatrics Council on School Health and is currently Vermont AAP chapter president. Dr. Frankowski did her medical school training at Johns Hopkins School of Medicine, pediatric residency at Rainbow Babies and Children's Hospital in Cleveland, and MPH at Rochester University School of Medicine in Rochester, New York. She currently lives in Vermont with her husband and has 2 grown daughters and 1 adolescent granddaughter. Dr. Marion Errol is the Director of Pediatric Programs for Community Care of North Carolina and lead on the North Carolina CHIPRA Quality Demonstration Grant. From 1994 to July 2012, she was the Medical Director of Guilford Child Health, a large nonprofit private pediatric practice that serves families at or below 200% of the federal poverty level in Greensboro, North Carolina. She is also a clinical professor of pediatrics from the University of North Carolina Medical School. She has many years of experience as faculty on QI learning collaboratives for pediatric primary care and serves on the steering committee of the Quality Improvement Innovative Network for the American Academy of Pediatrics. She is co-chair and improvement advisor for the AAP's National Bright Futures Improvement Project, which begins in 2015. Dr. Earls is medical director of the multidisciplinary Neonatal Development Follow-Up Clinic at Women's Hospital in Greensboro. Dr. Earls is the past president of North Carolina Pediatric Society. She's a member of the executive committee of the AAP's Council on Early Childhood, a member of the Mental Health Leadership Work Group of the AAP, and liaison from the AAP to the American Academy of Child and Adolescent Psychiatry. Dr. Earls received her AB in biology in 1976 from the College of Holy Cross in Worcester, Massachusetts, her Master's of Theological Studies in 1978 from Harvard Divinity School, Harvard University, and her MD from the University of Massachusetts in 1984. She is board certified in both developmental and behavioral pediatrics and general pediatrics. In their blended family, Dr. Earls and her husband have 4 children and 3 granddaughters. Our panelist today is Dr. Paula Duncan. She is retired as a professor of pediatrics at the University of Vermont College of Medicine in 2013. Nationally, she volunteers with the AAP Bright Futures Implementation Steering Committee, addressing the measurable implementation of these preventative services guidelines. Her main focus since the 1990s has been on incorporation of the strengths-based approach into adolescent healthcare with the identification and promotion of youth strengths and shared decision-making. She did residency training at Albany and Stanford, where she also completed her adolescent medicine fellowship and served as faculty for 5 years. She has received several national awards from AAP and MCHB, including the AAP Abraham Jacoby Award in 2011. She has lived in Vermont with her husband for 30 years and has 3 children and 6 grandchildren ranging from the ages of 3 weeks to 17 years. And without further ado, we're going to go ahead and turn it over to our first presenter today, Dr. Barbara Frankowski.
Okay, can you see my slides?
We can.
Okay, great. Thank you very much for allowing me to talk today, and I have nothing to disclose. And for those of you who don't know that much about Bright Futures, it's a set of principles, strategies, and tools that are evidence-driven and systems-oriented. The Bright Futures 3rd edition incorporated and replaces the other editions, and there's a 4th edition coming out soon. And it can be used to improve the health and well-being of children of all ages and their families. I always like to mention that the Affordable Care Act requires health plans to cover the services outlined in Bright Futures. That's sort of nice for us. And what are the quality measures for adolescent and young adult preventive services? This is sort of the short list of quality measures, and it starts with making sure that you elicit and address parental and youth questions and concerns. There's screening and follow-up that includes risk assessment and assessing the developmental tasks of adolescents, looking at BMI percentile, appropriate screening for chlamydia and HIV, screening for depression, and screening for dyslipidemia, both universal screening at certain ages and targeted for those at risk. It also includes anticipatory guidance, including counseling on nutrition and physical activity, immunizations, including Tdap, HPV, meningococcal, Hep A, and flu vaccine, physical exam, and using strength-based approaches to encourage needed behavior changes. We always want to make sure that we're identifying children and youth with special health care needs, and we want to try to assure yearly visits using a recall and reminder system. Whew, that's a lot that we're trying to do at these visits. And the periodicity schedule displays in chart format the recommendations for preventive care, with the blue area on the right including adolescence through young adulthood. And what are the Bright Futures visit priorities? There are 5 priorities for each age group, and for the adolescents it includes eliciting patient and, when appropriate, parent concerns and questions, assessing physical growth and development, looking at social and academic competencies, ensuring emotional well-being, looking at risk reduction, and violence and injury prevention. These priorities are supported by the Bright Futures tools, which include PreVisit Questionnaires, documentation forms, and patient and parent handouts. And I know you're not going to be able to read these, but this is just what the tools look like. So I always say, no way are you going to even start to be able to accomplish all those little dots on the periodicity schedule without a comprehensive, organized way to gather information. And that's what the core tools of Bright Futures definitely helps you do. From the PreVisit Questionnaire point of view, it allows the healthcare provider to gather information without using valuable time asking all the questions. The documentation forms are organized in a way that allows you to be sure you've covered the visit priorities and cues you to ask any additional information you may need based on the PreVisit questionnaires. And the patient and parent handouts supply reliable information organized, again, by the visit priorities. And in the interest of time, I'm just going to highlight the PreVisit Questionnaire, but the other tools are also very valuable. And I just want to make a note, again, not that you can actually read what's on this PreVisit Questionnaire, but these are the tools from the 3rd edition, and they'll be updated when the 4th edition comes out. So these PreVisit questionnaires can be filled out by the adolescent or young adult and parent when appropriate. It can be filled out before the visit, either in a paper version or an electronic version, or it can be filled out prior to the visit and emailed into the provider. And this is one example, but there are appropriate questionnaires to match various ages and developmental stages, with both basic and supplemental questionnaires available for younger adolescents to be used as appropriate. And that allows you, as the clinician who knows your patient population, to choose for the younger adolescents, 12, 13-year-olds, is it appropriate to ask detailed questions about sexual activity or not in your patient population? So you can choose the appropriate pre-visit questionnaires. And the questionnaires ask risk assessment questions, so that would trigger any recommended medical screening. It asks about the Bright Futures 5 priority topics. It allows the parent and the patient to note any special concerns, and it gathers information about the developmental tasks of adolescents. And just taking a little bit closer look at this, it sets the agenda. What would you like to talk about today? And cues in on the 5 priorities that we've mentioned before. And it also asks about the developmental tasks, like I mentioned. And there are questions about medical screening, asking questions about anemia, hearing, vision, etc. And then tells you what to do if the risk assessment is positive. So that's a very quick look, and I would definitely encourage people to get on the Bright Futures website, where you can actually look at if you're not familiar, you can look at the tools in more detail. And the templates, questionnaires, and handouts can be used in your electronic health record, and depending on your specific EHR, you can either import the documents or use them as a guide in setting up customized health supervision visit templates and pre-visit questionnaires. So what's so special about a Bright Futures visit? What really makes a Bright Futures visit? So let's meet Tiffany, and this is a lot more fun if I actually have an adolescent patient with me to play the part, but I'll try to do my best today. So Tiffany is 17. You're meeting her for the first time because she recently came into foster care in your county. She's currently living in her 5th foster home. She's in 11th grade, doing okay, but failing math. She has a past history of tobacco, alcohol, and marijuana use, and she's currently sexually active with one partner without protection. So you're thinking you have your work cut out for you. When you look at the questionnaire that she filled out, there's a couple of quick things that you find out that you can deal with. You find out that she was in a juvenile detention facility for a couple of weeks 6 months ago. So you might want to consider screening her for tuberculosis. She's sexually active, so you might want to consider screening her for chlamydia and possibly HIV. You find out her diet is almost exclusively vegetarian, and sometimes she doesn't really have enough to eat. In the past, she didn't really have enough to eat at times when she was couch surfing, and she took no vitamins or iron supplements, so you might want to screen for anemia. And she has a history of alcohol and drug use, so you might want to do a craft screening to see if she has problem substance use. So what about the developmental tasks of adolescents? Because this is probably the heart of a Bright Futures visit. So these are the assets or strengths that the adolescent should be attaining in order to become a happy, healthy, well-functioning adult in society. And in the words of Bright Futures, this includes demonstrating physical, cognitive, emotional, social, and moral competencies, engaging in behaviors that promote wellness, forming caring, supportive relationships, engaging in a positive way in the life of the community, displaying a sense of self-confidence and hopefulness, demonstrating resiliency, and demonstrating increasingly responsible and independent decision-making. So that's a lot of words. So how are you going to operationalize that in your mind when you talk with these adolescents? And in Vermont, when we presented various frameworks to conceptualize adolescent strengths to the practitioners, they chose using this circle of courage. And when you look at the words that go along with those four basic parts of the framework, you can see that it really easily incorporates the developmental tasks of adolescents in a way that's easy to understand. You don't need to use this framework yourself. There are several other frameworks, but this is one that the Vermont practitioners chose. So generosity is demonstrating honesty, caring, contributing to the family and community, and starting to develop empathy. Belonging is developing healthy interactions and relationships within and beyond the family. Mastery is finding something meaningful to do in life, learning and maintaining good health habits, and I always think of it also as starting to get control over your own behavior. And independence is establishing an identity and a sense of self-efficacy and practicing independent decision-making. And for people who are familiar with the HEADS version of interviewing adolescents, you can see if you use that mnemonic that you can also weave in the strengths concepts into that. Some people also prefer to ask about strengths up front, and some people like to use Ken Ginsberg's shades model. So whatever you feel most comfortable with, that's what you would want to use. So basically, a strength-based approach supports mastery, identifies strengths, starts with what is right, and if a behavior change is needed, uses the helping skill or shared decision-making or a form of motivational interviewing, depending on your skill level. So let's get back to Tiffany. And what you found out about her is that from the generosity point of view, she cares about her friends and her boyfriend, and she wants to become a social worker so she can help other kids like herself. From the independence point of view, she knows how to take care of herself and get around town without a car, and she's currently making healthy decisions on her own, not using alcohol, no longer using alcohol, tobacco, or other drugs. From the belonging point of view, she feels like she really fits in with her current foster family. She has a caseworker from another county that she's close with and has a good set of friends who don't use any substances. And from the mastery point of view, she's on track to graduate from high school if she figures out what she's going to do about math. So how do you put this together? And I'm going to do sort of a little quick role play with myself because we found when we've worked with practitioners in the past, if they actually hear and then have a chance to practice the words and how it sounds, it makes it easier to start to incorporate that for yourself. For Tiffany, you're worried about her risky sexual behaviors, among other things, but this might be the thing you're going to pick out as the most important that you're going to deal with in that visit. But you want to start with the positive. So you can say something like, Tiffany, I just met you today, but I can't help but notice that you have a lot of strengths. and then you can pick some of them to feed back to her so that she knows what you're talking about. Except for math, you're on track to graduate on time from high school, even though you've been in 3 different high schools. That's incredible. You're making a lot of healthy decisions on your own, like your decision to not use substances anymore, and that must have been really hard, but you're doing a great job with that. You have a lot of people that you care about and who care about you, and you guys watch out for each other. And I think it's great that you want to be a social worker. I think you make a great one. And Tiffany, did you know that people who have these strengths often have an easier time getting through rough spots in life and are more likely to become successful adults? So she might say something like, cool, I didn't know any of that. So you've sort of made that bond and started off on the right foot. But you have to deal with her risky behaviors. I'm really worried that you're currently sexually active without any protection. Is that something we can talk about? And hopefully she'll say yes. And then you say, help me understand this. Do you really want to have a baby right now? And in this case, she says, no, not now. So what choices can you make? What do you think you could do? And she says, well, I guess I could use a condom or have Trevor use a condom. Well, what would happen if you tried that? Well, we've talked about it before. Trevor doesn't really like to use a condom, and besides, we've already got ourselves tested for STDs, so and we don't have any, so we know we're okay from that point of view. Well, what else could you do? Well, I could keep doing what I'm doing. We haven't gotten pregnant yet. And what would happen if you kept on doing that? Well, Tiffany could say, I guess I might get pregnant eventually. What else could you try? What do you know about birth control? And she might talk about the pill, but she tried the pill in the past and she couldn't remember to take it. You might give her information about LARCs, and she might say, oh, I didn't know about that. That sounds kind of cool. Maybe an IUD would be good. So you make a plan. So Tiffany, let's make an appointment for you. So we did the pregnancy test today, and we know you're not pregnant. We have a screen for chlamydia, so we'll have that back in the next couple of days. So why don't we make an appointment for you for next week to get the IUD placed? And she says, well, I think I'd like to discuss it with Trevor first. And you're like, uh-oh. And what plan can you make? Say, well, how about either you discuss it with Trevor and then come back with him and we can discuss it together, or I can give you a call and give you and talk to both of you and give you more information, or my nurse can call, whatever feels right at the time. So that's sort of a way that using the information that you've gained from the PreVisit Questionnaire, making sure that you've asked the questions about strengths, and then being able to use that in a way that can help an adolescent make that decision. And one of the things that people have said when we've used this in the past is, well, you probably should have just stuck the depot in her arm the day she was there. And maybe you could have done that, but you probably would never have seen Tiffany back in your office again. Doing it this way feels much more respectful. She was involved with the decision, and now her partner will be involved with the decision also, and be able to be supportive. So that was just a quick little role play. In summary, the nice part about Bright Futures is that it helps you provide standardized care. All the forms are linked with Bright Futures, and the documentation form helps you track care over time. So if there's anything you didn't get to in a visit, you can make sure that that you fill in those blanks the next time you see the patient. And it obviously helps you provide individualized care. So the forms allow parent and patient priorities and concerns to surface, and gives you the opportunity to tailor care and anticipatory guidance and use a strength-based approach. So I just have some references, and I'm going to hand the controls back over so that Marion can give her talk.
Thank you, Barbara. I loved that discussion of strengths-based approach, and so it's a great segue into being able to talk about our experience in North Carolina. So I've called this Engaging Adolescents, the Community Care of North Carolina Experience. And I'm going to take this little bit of time to talk about how in North Carolina we have tried to help practices implement the principles of bright futures. And we've had a particular interest in social emotional development and supporting the strengths of adolescents and helping practices understand how it is that they can engage adolescents and keep them coming back. So Tiffany's story was a good example of getting her engaged in making the decisions so that she felt that it was a good place to be able to come back. So to start out our this discussion, I wanted to tell you a little bit about some great information that we got from teens before we got started with our adolescent work in North Carolina. So this was done in 2012, just about a year into our CHIPRA quality demonstration grant. We had a lovely young woman who was a rising senior in high school, quite articulate, and as we talked to her about our ideas for adolescents, she volunteered to develop a survey for us, which she did on SurveyMonkey, which was great because I don't have that technical skill myself. And she got this out to 13 to 18-year-olds, and it was very different than a lot of adolescent surveys. She didn't want to ask about what risky behaviors are you participating in. We've got lots of data on that, but she wanted to really ask other adolescents about their doctor-patient relationships. And she thought that we could get advice from teens on how practices could improve their relationships. So it's when you see these results, it's pretty exciting, particularly in light of what Barbara was just describing in terms of what the principles of bright futures in working with adolescents. What was interesting is that the adolescents' biggest concerns based on this survey were worries about their future, healthy weight, nutrition, and physical activity, and stress and anxiety. And the other sort of unfortunate thing that we discovered was that they weren't aware, for the most part, that they could have a discussion with their primary care clinician about their concerns in their family or depression or anxiety. There were some good things that they reported. Most of the teens surveyed that said that they went to the doctor, 96% of them. They said many of them saw the same doctor every time. The main reasons, not surprising, were sports physicals or annual physicals. But only 10% said they went to the doctor for social or emotional health issues, and that's kind of consistent with the previous slide. They didn't generally schedule their own appointments, which speaks to our struggles with helping adolescents transition to taking care of their own care. But only 12% thought they weren't involved with decisions regarding their health, which was quite good. So there were several things that they described, and you can read some of these things, you know, that teens said about would be important to them when they went to their doctor's office. One quote that's not here was from a student who said, I think that it would be useful for our doctors not to assume, sorry, my slide just switched, not to assume that all teenagers are doing alcohol, drugs, and sex. And there were several sentiments like that. Before this survey, I didn't even know depression was something that is normal to talk to your doctor about. I would like more alone time with my doctor because there are some topics I don't want to discuss in front of my mom. So it was really clear that adolescents were interested in the questions on the survey and were interested in making some suggestions about what would make their health care better for them. And I dare say that lots of you folks who are working in school-based centers, you probably do a little bit better job of this than some of us do in primary care practice. So again, here are the Bright Futures tasks of adolescents, and I show this again because when you think about the responses from the adolescents, you can see their desires for the visit are very much in line with what those tasks of adolescence and what that circle of courage talks about. So in North Carolina, our efforts around adolescents were that we wanted in the Medicaid program to promote annual EPSDT or annual well visits for all adolescents. We worked on a toolkit to help practices understand about how to routinely ask about strengths and risks. We developed some short videos, and I'll give you the link for that if you're interested in those, that tried to show ways of engaging adolescents and having that conversation. And in particular, there's a video on using motivational interviewing, our common factors approach. We had medical home learning collaboratives that involved practices from around the state. We developed a maintenance of certification part 4 for pediatricians and family physicians, specifically about the adolescent well visit. And Dr. Duncan, who you'll hear from, was a presenter on our MOC part 4. And just most recently, we developed co-management guidelines for adolescent depression screening. So I'm just showing you a couple of screenshots here, not for you to have to read the small print, from our Adolescent Toolkit. And this toolkit was developed by some of our primary care champions and our care managers in our Medicaid networks to talk about, do you know important facts about adolescents, what we need to do at those visits, and what teens think about those visits, with a little information about, if you are using social emotional screening tools, how you would bill for that in North Carolina. And then we had a one-pager to help them understand what are some primary tools that you might use to get at strengths and risks. So you heard Dr. Frankowski talk about the heads. We really promoted very heavily the Bright Futures Adolescent Supplemental Questionnaires that assess risks and strengths and cover many domains of adolescent life to look at social emotional development, sexuality, et cetera, et cetera. Some of our practices are still using the GAP, so the Guidelines for Adolescent Preventive Services. Doesn't quite do as well in asking about strengths as does the Bright Futures questionnaire, however. And then we also train practices on more specific screens. So you heard Dr. Frankowski mention the CRAFT if you're concerned about substance use. There are good depression screens. So we try to help people understand if an adolescent disclosed something to you that was concerning, here were some other screens that you could use. So we also developed these very short video clips on engaging adolescents, again, to talk about the importance of talking about strengths and risks, how to implement confidentiality in your office. You heard my quote from the adolescents on the survey who really wanted to have more alone time with their physician. There's a video on the common factors approach and how to engage an adolescent and use motivational interviewing. How to make your office, if you're school-based clinic, you probably do a lot better job than a lot of primary care practices on making it adolescent friendly. And then how to make a mental health referral if you actually need to do that. So we also had the medical home project that I mentioned, and that medical home project was focused very much on mental health competencies for primary care clinicians. And we actually looked at the whole population, from young children to school-age children to adolescents. I'm just showing you here our final aggregate run chart from that learning collaborative. So this is 2 cohorts of practices, 26 of them from around our state. And we were able to help practices get very good at implementing routine strengths and risk screening, primarily using the Bright Futures. And you can see that by the last several months of our project, they were in the 90 to 100% of the time that they were using a screening tool. We were also asking them to document that they discussed the results with the adolescent at that visit. And you can see we still need a little work in that area. Finally, we developed an MOC project, that's the Maintenance of Certification project. And you can see here that the flyer that we sent out to practices to participate in this activity, and the quality indicators that we asked them to look at every month. Did you use the supplemental questionnaire? Did you identify concerns? Did you take an action? And if there was a depression risk, did you follow up with a depression screen? Were you doing BMI percentile documentation and counseling? And how were you doing on those immunizations? We were really interested in them changing their practice system to make sure that this became routine, that they did well with confidentiality, that they developed a recall system for immunizations, and that they developed some system for referral and co-management with mental health professionals if they needed to. So just real quickly, a little bit about pre and post on our first group of people who did the MOC Part 4. You can see we had tremendous success in getting them to use a routine tool in developing a recall system. They said they already talked about social emotional issues, but that also improved. And they improved in their ability to implement confidential processes. In terms of their baseline, midline, and final activities, you can see here how they did on all of these and how they pretty much steadily improved in all of these. And then in HPV, I don't know exactly what happened midline, but finally, the rates of HPV vaccination for both boys and girls reached better than the average reported by the CDC. So the impact of this was that we had 25 participants completed the original rollout of this MOC Part 4 project, but we've had 53 additional participants complete the course, and we have another 27 that are completing it now. And I just included a quote here from one of our pediatricians who said, "My participation has transformed my approach to adolescent well care," which is exactly what we were after. Doesn't mean that it became perfect, but people really were very engaged about the idea of particularly addressing strengths with adolescents. And most recently, we've worked on co-management guidelines for adolescent depression. You may be aware that that's now a meaningful use measure. And of course, it is a recommendation in the Bright Futures periodicity schedule for adolescents as well. We brought together some of our child and adolescent psychiatrists that work with us in CCNC and some primary care clinicians and developed a set of co-management guidelines for people to work together to address these issues with adolescents. So in this particular instance, we not only use the Bright Futures guidelines, but also the American Academy of Pediatrics Mental Health Toolkit guidance. And here's our nice little algorithm here. I just want to point out that it starts at the well visit with using the Bright Futures Supplemental Questionnaire, or HEADS, if that's what the practice is used to using, to move to a PHQ-2 and then address and then go from there in terms of making their decisions on whether there is depression present and what referrals need to be made. So in summary, our work with adolescents has been around promoting resiliency and reducing risk. Again, very consistent with the Bright Futures tasks of adolescents, and also very reflective of the request of adolescents on our survey. So to affirm and support current strengths, to encourage goals, to elicit interest, and share resources for building that sense of generosity and belonging. And I'll turn this back over to Paula.
Okay, thank you so much to Dr. Frankowski and Dr. Earls. At this time, I would like to open up the floor for any questions. You can do so by typing them into your chat box, in the control panel. It looks like there are no questions quite at this time, but I do want to remind everyone that you are open to typing those in now. We're just going to go over some kind of concluding remarks as we're waiting for those questions to come in. So I want to remind you that our convention is coming up. It's our 20th anniversary. So go ahead and register today if you're interested. It's at sbhforall.org/convention. We are a membership organization. If you're interested in becoming a member with us and all the benefits that come with it, go to sbhforall.org/membership. Let's see. It looks like there is one question in the box here. So this comes from Jacqueline. Oh, never mind. I'm pushing technical questions. So it looks like there are no questions at this time. I'm going to leave just a couple minutes here for people to kind of file those in, if you wouldn't mind just hanging tight. Okay, Arlene has a question. In our school-based clinics, we have noticed over the past year that when an adolescent is getting a pregnancy test, when asked if we can also do an STI test, most decline. Any suggestions on how to approach this?
Hi, this is Barb. I'll go ahead and take a stab at that. Can you hear me?
Yes, we can.
Okay. I think one of the problems with doing the STI testing is to be sure that that there's confidentiality. And I know that for some, depending on how you're doing it in your school-based health center, if you're billing it to their private insurance, then it does show up on the explanation of benefits. Not an issue if they have Medicaid or if you're billing it some other way. But I think maybe in the way you you approach it, not so much, you know, would you like to have the STI testing today, but maybe in a positive way. It's really important, along with the pregnancy test, it's really important for your health and well-being to also make sure that you don't have any infections. We can do this with the same urine sample that you're getting for the pregnancy test, depending on how you have them collected, and sort of making it a positive, you know, that they have to opt out rather than opt in. So that's how I would approach it with them. Although I will admit that in our school-based health centers we have the same issues, that for some reason the kids see that as different. But taking that approach, I've been more successful. And I don't know if you know, Marion, if you have any suggestions there.
No, Barbara, I think that was a great response.
Okay, great. So we have a couple questions about people asking if the presentation is going to be available after this to take another look at the slides. The answer is yes. We do post those on our website. If you just give us a few days, you will be able to have a full PDF of everyone's slides. Okay, so our next question comes from Tammy. Do you use the GAD-7 for evaluation of anxiety?
Sorry, I had to take myself off mute there for a second. Actually, it's not one of the tools that our practices have been using. Many are using the SCARED. I'm interested to know what people's experience is with using that. I think the importance is to identify, particularly in our groups, to identify a tool that's fairly simple to use, that the adolescents themselves can complete, and it can be rolled into a visit in an efficient manner. So I think if you have the tools that we use, you could, I will mention some of the ones that were on that, on our one-pager for practices. You notice there were quite a number of tools that we suggested there. And we just really encourage people to use a good validated tool and something that can help them engage the adolescent and the adolescent can complete in an efficient manner.
Yeah, and this is Barb. Actually, we tend to use the SCARED also, although I hate the name, so I've made paper copies without the name on it. And I think it just depends on what works well for you. We don't use it routinely. We do use the PHQ-9 to screen for depression routinely, and then the SCARED would be a secondary if we think that it's more of an anxiety issue. But again, whatever works best in your practice.
Okay, at this time it looks like there are no more questions. Feel free to continue typing those in. If we don't get to them today, we can certainly follow up via email. So some closing reminders. As I mentioned at the beginning of the presentation, this presentation has been recorded and will be archived on the School-Based Health Alliance's website within the next 2 to 3 business days. If you'd like some more information about preventative care, please send us an email at programs@sbhforall.org. We have just 3 short poll questions for you to see how you felt about today's presentation. If you wouldn't mind answering those when they pop up on your screen here. So our first question, did this presentation meet your needs? Okay, we'll give you just a couple more seconds to go ahead and get those answers in. Okay, did this presentation provide you with usable ideas and/or techniques? Okay, we'll give you just a few more moments to go ahead and get those answers in. Okay, and our last question, would you recommend this webinar to others? Okay, just a few more seconds here. Great, so at this time we have no additional questions. However, if you do have any questions that you kind of think of after the presentation, please do not hesitate to contact programs@sbhforall.org. I can also follow up with the presenter's email. And I'd like to say a special thank you to Dr. Frankowski and Dr. Earls for joining us today, as well as Dr. Judkins. So thank you guys so much and enjoy the rest of your evening.
Great, thank you.